So first, we're going to look at the process of filtration. Again, that's happening in the renal corpuscle with the glomerulus. So remember the podocytes? So those, specifically the feet, are called pedicels, are forming filtration slits. So for filtration, remember this is the visceral layer of the glomerular capsule. So we have filtration membranes because of those filtration slits. So materials from the glomerular capillary, so the glomerulus, is going to go and pass through not only the fenestrations of the capillary, because it is fenestrated, but it's going to go through kind of this filtration membrane, making sure any larger molecules like blood cells and proteins that you don't want out are going to not be able to pass through. So it's maintaining all of those, but all the other solutes are going to be able to pass through what we call the filtration membrane between the fenestrations of the capillaries and the feet or the podocytes. So just another kind of example, you can see on here, the glomerulus is the red, and all of these kind of little legs area are going to be the pedicels or the feet of the podocytes. So this is a podocyte right here. Here's the nucleus. So that's covering all of that. So again, you're looking at the fenestrations or the pores of the capillaries because it is a porous or fenestrated capillary. And then you have the feet or the pedicels of the podocytes. And you have this whole filtration membrane. So solutes have to go through here to get into the capsular space. So the capsular space, again, is all this part because this is the parietal layer of the glomerular capsule. And then this is the visceral layers, the podocytes. So when we come in, the afferent arteriole, so it kind of got cut off here. So afferent arteriole is going to bring in blood from the cortical radiate arteries and delivers blood into the glomerulus. And then we have the exit or the efferent arteriole that's exiting after filtration's occurred. So this is everything that's left over that we've already pushed out into the glomerular space. So efferent arteriole, again, going kind of over circulation. So efferent arteriole is going to lead into the peritubular capillaries. You are going to see a difference in size. So if you look at the afferent coming in from the cortical radiate artery, it's larger. So look at this versus look at the size of the efferent arteriole. So the smaller diameter of the efferent actually causes backup or slowing down of blood in the glomerulus, because you can think of it, if you have double doors coming in and they're wide open, so you can have more people come into your room versus you only have one door leaving. Well, it's going to be harder and it's going to slow down the exiting process versus the entrance process. That is going to increase the blood pressure in the glomerulus because less blood is flowing out, so more is going to stay in the glomerulus. It's going to put more pressure on the sides of the glomerular capillaries walls, and it's going to increase the pressure on them. So it's going to put more pressure on the walls of the capillaries of the glomerulus. So we're going to increase blood pressure. And that's going to come into play when we talk next. So sometimes if we have large molecules that get stuck in that filtration membrane between the pores of the capillary and of the glomerulus and the podocytes, then we can get rid of them. They're actually engulfed or phagocytized by mesangial cells. But anything that's smaller than those large proteins that you don't want to get rid of in cells, then you're going to allow them to pass. So again, water, glucose, amino acids, those waste products. but it may, just kind of like before, plasma proteins are going to stay in the blood. And it's our old friend colloid osmotic pressure that's going to help kind of be an opposing force to filtration with the plasma proteins. So we do want to push out a lot of water into the filtration, but we don't want to lose it all because then your blood's not flowing. It's going to be a bunch of sludge. So it's just going to be proteins and cells. Well, it needs to be suspended in something. That's water. So you don't want to lose all your water. And your colloid osmotic pressure caused by your plasma proteins is going to help with that. If you are seeing proteins in the filtrate and you're seeing proteins in urine, because if it's not, it goes all the way down from the filtrate to the urine, then you're looking at a problem at your filtration membrane. So between the glomerulus and the podocytes as well. So looking at pressures again, hydrostatic pressure. So we're promoting filtration formation. So or filtrate formation. So we're promoting filtrate. So we're promoting leaving the glomerulus. Hydrostatic pressure in the glomerular capillaries. It's like glomerular blood pressure. So like we said, with the afferent being larger than the efferent arterioles is going to increase blood pressure. Well, it's increasing our hydrostatic pressure. So that's the force of pushing things out. Solutes, water, things like that. And because we have smaller efferent, then we have actually higher pressure in the glomerulus. We do want to make sure we're pushing out a good amount of water and solutes so we can filter through. So we do have a higher hydrostatic pressure so that we can get a little more kind of into the nephron to sort through. Because you usually see it's kind of more than double in other capillary beds. So that's why, again, smaller efferent is going to make it higher resistance because of the smaller diameter than the afferent, and that's going to increase the glomerular hydrostatic pressure, the glomerular blood pressure. Then we have opposing forces. So inhibiting filtrate formation is opposing filtration. So there's actually pressure, hydrostatic pressure, that's in the capsular space. So what happens, again, see capsule, we have the glomerulus. Well, as we're pushing out and fluid's going to be filling the capsular space, well, that's going to impose a pressure as well because the fluid's going to be in that space and it's only a certain area. So as you fill that space, you increase the pressure. So that is an opposing force. It can go against the other side of the glomerulus, so trying to keep things in. And we already mentioned the colloid osmotic pressure is because of proteins in the blood have a pull on water, so they want to keep the water with them. And so water's torn between going out or going back in. So that's going to be an opposing force as well, is that water got pushed out and then it's like, oh, I don't know where to go. I don't know where to go. Do I go out? Do I go in? And so that's going to be kind of the opposing force. So then we have net filtration pressure is the sum of the forces. So we have 55 is going to be our out force. So that's going to be your hydrostatic pressure in the glomerulus. Minus, if you're looking at 15 for hydrostatic pressure in the glomerular space, and 30 for that pull of proteins back into the capillary, so colloid osmotic pressure, 30 plus 15, 45. So the net force is 10 millimeters of mercury. So that's going to be what is pushing and causing filtrate formation. So we look at we can look at it as a rate as well. So this is glomerular filtration rate. So it's how much filtrate we're making in a unit of time. In this instance, is usually per minute. So this is looking at how much filtration your kidneys are doing per minute. And it can look at health of the kidney by looking at GFR, glomerular filtration rate. So looking if it's too high or too low. And this is a value we can actually look at to make sure that our kidneys are doing what they're supposed to and are healthy. So this is just a larger picture of looking at. So we have our plasma proteins inside our glomerulus. So that is going to be calling water back. So it's saying, come back, water, come back. And that's causing the blood colloid osmotic pressure. So again, water's like, oh, these are really large solutes. They want to stay with it. So blood colloid osmotic pressure, opposing force. In this instance, it's 25. Before we said 30. The numbers aren't important, just knowing directions is. Then you have the capsular hydrostatic pressure. So it's the pressure that is filling this area, the capsule. So we have fluid in here, so it's going to exert a pressure kind of on both walls. So it's going to push against both. But the force against the glomerulus is going to oppose movement. So again, if you're trying to go down the street where everyone else is going, well, you're going to slow down movement because you're kind of going opposite direction of everyone else. Then we have glomerular hydrostatic pressure. So that again is blood pressure that's happening in the glomerulus that is pushing out. So pushing solutes, fluid, all of that out. So we have our opposing pressures, and we have so blood colloid osmotic pressure and our capsular hydrostatic pressure opposing our glomerular hydrostatic pressure, but we have a net of about 10 millimeters of mercury. So we have a net of filtration. So then we can collect and it can go down the proximal convoluted tubule and we can pick through it. So that's going to be, again, kind of movement of fluid. It's all dependent on blood pressure, hydrostatic pressure, the pull from proteins of water to go and solutes to go back in, blood colloid osmotic pressure, water to go back in, and then the force of all that fluid being pushed out kind of then backfires and pushes against it again of the capsular hydrostatic pressure. So I mentioned this already. Glomerular filtration rate, or GFR, is the amount of filtrate per minute. So it's a rate. So it's per unit of time. In a normal adult, again, this is average, about 125 milliliters per minute is your GFR, or 48 gallons. Think of gallon of milk, how much that is, per day. But remember, we're not losing that much. That's a lot. 125 mils, 48 gallons a day. 99% of it is reabsorbed. So, two ways that we actually can regulate and change our glomerular filtration rate. It's not always the same number. It can change based, again, what's going on inside the body, whether we need to change it based on what's happening in the nephrons or in the environment or help happening in the rest of the body. So we have two ways of regulating it. One is auto regulation. So auto means self. So this is self-regulating. Self. So the kidneys can adjust their GFR by responding to things like changes in blood pressure and volume and what they're kind of sensing that's going on. Central regulation, the kidneys can't handle it themselves. So they call for help. So they make a call to the central nervous system, so central response, that's going to change the GFR by using more systemic ways. And it's when the kidneys can't do their self regulation. If they can't solve the problem themselves, they're going to call for help because the kidneys are very sensitive to things. They want their kind of normal environment and their normal blood flow so they can do their function. So if they need to, they're going to call for reinforcements. So first talking about renal autoregulation. So again, this is kidney self-regulation. And this is how the kidneys can maintain a pretty constant GFR by themselves. And they can maintain a constant GFR when this map is the mean arterial pressure. So when blood pressure is within 80 to 180 millimeters of mercury, then it can adjust based on what's going on. If it's closer to 80, it's going to adjust and change its GFR that way. If it's closer to 180, then it's going to change that way. So it's just able to adjust up and down, up and down, up and down based on blood pressure that's happening um, in the body. If you're out of that range, the kidneys cannot fix it. They have to call for help. So then you're going to get to your central regulation. So there's two ways that the kidneys can auto-regulate or self-regulate the amount of glomerular filtrate per minute. There's the myogenic mechanism and the tubuloglomerular feedback mechanism. So first is myogenic. So genic means forming or making, and myo means muscle. So this is going to be because of smooth muscle. So what happens, this is going to be in the afferent arteriole, so the entrance part. We can control blood flow based on stretch. So if you have an increased blood pressure for whatever reason, and that is going to cause stretch receptors to realize that you have an increase of blood pressure, you're actually going to constrict your afferent arterioles, which is kind of opposite of what you would do kind of if all of a sudden increased blood pressure and it's too high to other organs, you're going to dilate trying to release that pressure. Increased blood pressure, you're actually going to constrict or you're going to make the diameter smaller. So you have a large afferent arteriole, all of a sudden increased BP, down, constrict it. Why do we do it? It's because we're going to restrict blood flow into the glomerulus because all of a sudden, if you have a blood pressure of 80, a map of 80, and blood flow is coming in, and all of a sudden you go up to 180, well, that's squirting blood a lot faster than when it's at 80. That's too much for the kidney to handle. So you're just going to shut your door or make it a lot smaller so there can't be as much blood to go in. So it's actually a protective way because it's going to be too much blood for the glomerulus to handle. So if you're shutting your door or at least closing it halfway, it's just so you can kind of manage what's coming in again. So you don't have an insane influx of blood. You can just get it back to your normal blood flow and go back about your business. Opposite is if decreased blood pressure, you dilate the afferent arterioles because of the same kind of principle. If you have kind of a normal afferent arteriole, blood pressure is coming in and you have blood flow, and then all of a sudden your blood pressure decreases, so it's going to be less blood flow, well, then you're going to increase your diameter because you want to let more in. As much as you can, you want to let more blood flow in. Again, maintain the glomerular filtration rate so that you can maintain your level of filtrate looking through the blood and you are able to continue to make urine and function, filter through all of what's going on in the plasma. So increased blood pressure, constriction. Decreased blood pressure, dilation. Both of the afferent arterioles. And this again is an autoregulation. There's stretch receptors, so smooth muscle is either going to contract or relax based on what's going on. So the kidneys can just regulate how much blood flow is coming into them. Blood flow can affect blood pressure, which is going to affect glomerular filtration rate. Now we're looking at tubular-glomerular feedback mechanism. So we have some macula densa cells that are going to be recognizing sodium chloride concentration in the filtrate, in the tubules. So if GFR increases, then you are having more filtrate formed per minute, because remember glomerular filtration rate. So you increase GFR, you're increasing the amount of filtrate you have per minute, which is going to increase its flow. Faster flow times means you have less time to reabsorb. Think about if you're on a factory line, kind of old school, where you're picking out something. So all of a sudden you're picking up apples or whatever is kind of going down the conveyor belt. Well, if it's just going at one speed and it's kind of walking along, well, you can do your job and pick out all the apples that you need. Think of all of a sudden it doubles its speed. Well, there's only so fast you can work, and picking out the apples that you're going to miss them. So you have decreased time to reabsorb by doing that. So you're increasing your rate, it's flowing by really fast. You can't pick out all the sodium chloride that you want to. So that's going to cause an increase in sodium chloride in the filtrate because you can't pick it out. So looking at the sodium chloride concentration, if it increases, is going to cause constriction of the afferent arteriole. That's going to, again, we looked at with blood pressure, it's the same thing. It's going to decrease blood flow, which is going to decrease GFR back, so you have more time for sodium chloride reabsorption. Opposite is true. If you have decreased GFR, then you're going to dilate and increase blood flow, which increases glomerular filtration rate. And that's kind of when you're having too little sodium chloride in your filtrate. So you have not enough. So now looking at extrinsic controls, so these are going to be central ones. This is no longer renal autoregulation. This is where outside the kidney. So nervous system, central nervous system, and hormones. So this is going to change systemic blood pressure. The autoregulation is just either dilating or constricting the afferent arterioles. This is controlling the entire body. So this again is when the constricting and dilating of the afferent arterioles cannot change enough the afferent or the GFR, then we need to change it systemically. So it's going to be overridden by these systemic controls. So sympathetic nervous system, so fight or flight. Remember that is going to be at rest. If you have the sympathetic nervous system, it's going to cause the renal blood vessels to actually dilate. But then the renal autoregulation is going to prevail. So it's going to be able to, if blood pressure is going to be too high, it's going to constrict. So renal autoregulation can take over. If you are getting to the point where you have extreme sympathetic nervous system. So this is going to be abnormal. So low blood pressure, a lot of times the sympathetic nervous system will kick in and it'll try to help kind of overall. So norepinephrine is going to be released by the sympathetic nervous system. Epinephrine is also released by the adrenal medulla, and that's going to cause, again, we're having low volume, low blood pressure. So low blood pressure is going to cause systemic vasoconstriction to increase that blood pressure. Because of this systemic vasoconstriction and the increase of blood pressure, the kidneys are going to do the opposite. So you're going to have those constriction of the afferent arterioles as well to decrease GFR, decrease the amount of flow that's going in there. So you get decreased GFR, also allows water reabsorption, sodium reabsorption. So we're going to make sure we're keeping as much as possible inside the body to help maintain that blood pressure as well. So blood volume and pressure is going to increase. We also have another way is the renin-angiotensin aldosterone mechanism. So renin is released by the kidneys, and then aldosterone has an effect on the kidneys. So we have this way of increasing blood pressure again by keeping sodium, more sodium than normal, and water follows. So renin is released by granular cells that are going to be in the kidney as well. So you can either have direct stimulation by that sympathetic nervous system if we're saying low blood pressure and we need to increase it. The macula densa cells are seeing that filtrate concentration of sodium chloride is low. Aldosterone is going to increase kind of changes in that. And then reduce stretch of granular cells as well. So reduced stretch means kind of lower filtration rate. So we need to increase our filtration rate again. So looking at auto-regulation, again, you have decreased GFR and that causes decreased urine production. So you have dilation of your afferent arterioles. You also can have constriction of the efferent arterioles even more. So this can even lead to it. We're looking more at the afferent, but you can even have constriction of the efferent, not afferent. Afferent is what we've been talking about. Efferent can constrict as well. So then you're even increasing the kind of decreasing the speed of going through so you can increase your GFR. So you have increased glomerular blood pressure by increasing the entrance and decreasing the exit. So you have a buildup and an increase of blood pressure. And then you get back to normal GFR because it's no longer decreased. You've increased the blood pressure and allowed the GFR to get back to normal. So again, auto-regulation is changing the blood vessels. If you're looking at the auto-regulation is not working well enough, then you have renin produced. Renin going into the bloodstream makes angiotensin 1 that's converted or activated to angiotensin 2 by an enzyme called angiotensin converting enzyme, and it's actually in the lungs. Angiotensin 2 at certain levels can help constrict systemic arterioles and can further constrict efferent arterioles, so it can help with autoregulation. But the major one is going to be aldosterone. Aldosterone, again, increases sodium retention. Sodium, water follows. So you're going to increase blood volume by increasing your reabsorption of sodium and your reabsorption of water. You also have a central nervous response to angiotensin II. You're going to be thirsty. So thirst centers, you're just going to start drinking. That's going to help increase your blood volume because you'll absorb it in your digestive system. You also produce and release ADH from the posterior pituitary. Remember, that's anti-diuretic hormone. What's going to happen is that's going to cause more water reabsorption in your distal convoluted tubule and your collecting ducts. You're also going to do other things. So again, if you're noticing that small reduced GFR, so you need to increase your blood pressure and your volume, you'll increase your cardiac output. So your heart is going to change. You're going to constrict your peripheral blood vessels. Anything that you can do to increase systemic blood pressure. So you're going to do everything you can to increase blood volume, which will increase systemic blood pressure, and other ways that you can further increase blood pressure. This is because, again, of a reduced GFR, so increased blood pressure, increased blood volume is going to increase your glomerular pressure, which is going to increase your glomerular filtration rate back to normal.